From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
My name is Dr. Cynthia Armand, Associate Professor of Neurology at the Albert Einstein College of Medicine, Montefiore Medical Center, and JAMA Neurology web editor. Artificial intelligence, also known as AI, has been a burgeoning topic of interest in various industries. Today, we are bringing it to neurology, specifically in regards to epilepsy and EEG interpretation. I have with me Dr. Sándor Beniczky, who is a professor of neurology at Aarhus University Hospital and head of clinical neurophysiology at the Danish Epilepsy Center. He also serves as editor-in-chief of Epileptic Disorders. Today, we are discussing the work of him and his colleagues entitled Automated Interpretation of Clinical Encephalograms Using Artificial Intelligence. Dr. Beniczky, welcome to the podcast today.
Thank you for the invitation.
I'm very excited about this topic, and what I wanted to start off with is what is known in terms of artificial intelligence in this space of epilepsy and EEG interpretation.
So artificial intelligence, AI, has been used previously for interpretation of EEG, but on very specific domains like finding epileptiform abnormalities or just distinguishing between normal and abnormal recordings. And the other limitation in the previous studies was that mainly they focused on short epochs, like 1 or 2 seconds of EEG, which is not the real world scenario where you have a 20, 30 minutes standard recordings. So what we focused on here is an interpretation which is fully automated and comprehensive. So not just finding the interictal epileptiform discharges, but also other types of abnormalities.
I see. So we're looking for this to become basically very thorough interpretation of EEGs, essentially, correct?
Right. So when I said comprehensive, I meant a subclassification of the abnormal recordings. So after distinguishing the abnormal from the normal, what our model does is classify them into 4 major categories: focal epileptiform, generalized epileptiform, focal slowing, and diffuse slowing. And this granularity is sufficient for clinical decision making. So that's why we targeted this level. Now, the use case, this can be used instead of experts in the underprivileged areas where expertise is totally missing, but also in the advanced centers, it can be used to help the physicians to pre-score or pre-select the recordings because the workload is really, really high. So we could all benefit from help from the artificial intelligence.
I see. So, this is great in terms of the potential for meeting the high demand that's necessary in neurology and diagnosis of epilepsy. Your model, it's called SCORE AI?
Yes, that's correct.
Okay. Now, when we start out talking about this, there's huge potential for this. And we want to make sure that this interpretation is just as good as us neurologists who have practiced for years, undergone training. How did you start out by designing SCORE AI to make sure that it has utmost accuracy in order to begin this type of study?
Right. So the trick is basically also hidden in the acronym. So SCORE stands for Standardized Computer-Based Organized Reporting of EEG. So this is a structured annotation system, which we developed more than 10 years ago, which has been endorsed also by the International Federation of Clinical Neurophysiology and the International League Against Epilepsy, the European branch. So we have standardized annotations, which we put as labels into the EEG reader when we spot an abnormality or even the normal patterns. And then this automatically does 2 things in parallel. It generates a report, but it also feeds the data into the database. Now, this huge annotated database, structured database, helped us because this was the basis of training the artificial intelligence model. So we had a huge data set from 2 large hospitals of more than 30,000 annotated EEGs, and these were scored by 17 different physicians. So different technicians putting on the electrodes, different physicians scoring the AI. So this helped in developing something that is generalizable. So we trained this model on this huge data set of full EEG recordings, and we do believe that this is the key of success of our model.
Oh, that's excellent. Now, tell us about the setup of your study design, what your goals were, and the outcomes you were looking at.
So our goal was to achieve in scoring or classifying the EEGs at this level of granularity, which I've just mentioned, to score them at similar accuracy as the trained human experts. Now, we did a very, very thorough validation using 3 different data sets, and all data sets were independent. And this is very, very important because that's why many people become disappointed when trying to apply models which others have developed, and then they find out that it does not work in their data set. So this is the lack of generalizability. Now, to make sure we will not fall into the same trap, so we trained first the model on a large data set from different centers, and then we validated it on independent data sets. So new machines, new patients, new physicians who provided the gold standard. Now, the first data set was large, almost 10,000 EEGs from a single center, but that center did not participate in training the algorithm. Now, those almost 10,000 EEGs were evaluated by 14 different physicians. The second independent data set was a representative multi-center, multinational data set of 100 EEGs, which was scored by 11 physicians. And here we used the majority consensus for gold standard. And then the third data set had an independent reference standard or gold standard because we had derived it from the conclusions of the long-term video EEG monitorings, which is independent from the interictal abnormalities which are scored by the model. So we had a very thorough and complex approach for the validation.
Now, the EEG recordings that were being looked at, I know EEGs can run for hours, 24 hours, 72 hours. Were they done in snippets to take a look at short time frames, or were they more longitudinal?
So the analyzed recordings have an average duration of 30 minutes, which fits with the standard recordings. Now, how the model does it? Well, it evaluates it in 2 steps. So first, it evaluates 16 seconds windows, and then it integrates the 16 seconds windows into a whole recording level. So you get, at the end of the processing, you get a bottom line result that is, okay, this recording is normal, or this recording has focal epileptiform abnormalities. And then going back to the Windows level, it also highlights you where those abnormalities are.
Ah, that's very good. Now, let's talk about the results in terms of its accuracy. I know it was being compared to real live human readers. So let's talk about that.
Right. So we had 11 experts who evaluated the multi-center data set. And then first we looked at the inter-rater agreement between the experts because, often it is stated that EEG per se has a low inter-rater agreement. But here we also have an interesting finding. So the previous studies with relatively low inter-rater agreement looked at screenshots, but that's not, again, the real life. So here we asked the raters to score the whole EEG at this granularity with the 5 categories, so the 1 normal and the 4 abnormal. And then with this approach, we believe fits much better with the real life scenario than looking at screenshots. So with this approach, we found that the experts had substantial and for one of the categories, even almost perfect agreement. So when it came to deciding whether the recording has any generalized epileptiform discharges, even the experts had an almost perfect agreement. For the rest, the agreement was substantial except for focal non-epileptiform, so for focal slowing, where the agreement among experts was high moderate. And it was also high moderate when there were several abnormalities, several different types of abnormalities in the same recording. Now, the agreement between the AI model and the consensus majority of the experts was at least as close to the gold standard as the average of the individual experts. So there were two domains, namely where the model came actually closer, significantly closer to the consensus majority decision as compared to the group of experts. And this was on distinguishing normal from abnormal. So here the agreement coefficient between the majority consensus and the AI model was 0.9. For the experts, the average experts, this was only 0.7. And also when multiple abnormalities were present, then the SCORE AI model reached an agreement which was substantial, 0.69. And then the average experts was only in the domain of moderate agreement, that was 0.49.
Definitely significant results. And it really calls to attention perhaps the worry that some individuals may have with this type of technology. If this is doing the job of helping with increased demand, we want to make sure that it's as accurate as possible. And you're showing that in some domains, it's even better than the expert human readers, which I think is quite something. Where do you see the rest of your research in this realm developing? Where do we go from here?
Well, we have lots of plans. So this model is optimized for standard routine recording, so 30 minutes recording. So our next project is to integrate this for long-term monitoring. So this is a longer time window. So that will be our next project. Then we would like to increase the granularity. So, for example, not just state that this is a focal epilepsy form, but state that this is a left temporal focal epilepsy form abnormality. So increase the granularity in subclassifying. So increase also the spatial resolution of the outcome of the model. Then another development is decreasing the number of sensors. So now the minimum number of sensors which we need for this recording is 19. So that's the classical 10-20 setting of EEG. Now we are working on decreasing this. I know this sounds ambitious, but we would like to decrease this to just one EEG channel. So basically you could get in an ambulatory or outpatient setting a basic EEG diagnosis just by sending wearable device to the patient. The patient could put the device on his or her head and then make a short 20-30 minutes recording with just a single channel, send back the data, and then the AI model would analyze this single channel. So these are our next projects.
Yeah, so not quite ready for prime time, but certainly well on its way. And in the strategy that's involved with this type of project is certainly fascinating and well worth the time. Dr. Beniczky, thank you so much for this work in this realm. I'm certainly looking forward to your next projects, certainly.
Thank you for the invitation, and I would like to take the opportunity to thank my colleagues and friends who helped me in developing this project, especially Jesper Tveit, who is the first author in the paper, and my friend and collaborator, Harald Orlian.
Thank you for listening to the JAMA Neurology podcast. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. This episode was produced by Daniel Morrow at the JAMA Network. This is Cynthia Armand. Thank you for listening.